For the first session, which is on traumatic brain injury, current guidelines and recommendations, I would like to invite our first speaker of the day, Dr. Pawan Verma, who is Associate Professor in the Department of Neurosurgery, SGPGIMS, Lucknow, on the podium. I would also request the chairpersons of this session to please grace the stage. I would request Dr. N.N. Gopal sir, who is a very eminent neurosurgeon of our city, to please come on the stage. He is our first chairperson of the first session. Dr. Arvind G, he is neurologist and currently Assistant Divisional Medical Officer at Central Railway Hospital, Prayagraj. So please come on the stage. And our third chairperson for the first session is Dr. Vaibhav Srivastav, sir. He is professor in the Department of General Surgery, MLN Medical College, Prayagraj. So please come on the stage.
And he had done his graduation and post-graduation from Kanpur and MCH from Jaipur. He is one of the very renowned neurosurgeon who is working on DBS in North India, and he is very much interested also in the traumatic brain injury surgeries and spine surgeries, and he is working also in the Apex Trauma Center at SGPGI Lucknow, and to his credit, he has 45 publications and book reviews. His area of interest is CV junction, and he is also having, he is working very well, and he is doing the deep brain stimulation surgery and functional neurosurgery. I invite Dr. Pawan to present his paper. Thank you.
Thank you, sir, for your kind introduction. First, I would like to thank organizing team of AMA Prayagraj for inviting me and sharing my view on traumatic brain injury. My special thanks to my senior Dr. Pankaj Gupta and Verma ma'am, who has invited me for this talk. Thank you, boss. So let's start with introduction. It's defined as a non-degenerative, non-congenital insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of cognitive, physical, and psychosocial functions with an associated diminished or altered state of consciousness. Traumatic brain injury is considered as a silent epidemic of modern times. It's worldwide, not in India. Because of the rapid growing economy and urbanizations, India has become the capital of traumatic brain injury in the world. And it occurs most commonly in the young males, especially below the 44 year of age, who are the major productive age group for this country. TBI is classified as a mild, moderate, severe, depend on the Glasgow Coma scale. And among all type of the TBI, mild TBI is the most common. It's 50 to 60% alone, depend on the institute and the level of the care. In 1980s, the Brain Trauma Foundation, in collaboration with the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, developed the first evidence-based management guidelines for severe traumatic brain injury. Joining hand with them, our colleagues, Dr. Matthew Joseph, Dr. Sumit Sinha, Dr. Dhawal Sukla, and Dr. B.D. Sinha, done a tremendous job to develop the Indian national guidelines for the management of traumatic brain injury for all kind of cases, mild, moderate, severe, and they have published this book in 2022. So if we talk about the epidemiology of the traumatic brain injury, a recent national survey review of road safety in India, based on the data from the 5-year Bangalore Road Safety and Injury Prevention Program, indicate that nearly 20% of the emergency registration and 10% of the emergency admissions and 1/3 of the hospital deaths are due to the road traffic accident or some kind of the injury. And more than half of them have TBI component. In a nationally representative mortality survey of 1.1 million homes, it was estimated that nearly 1 million injury deaths occur every year, and 60% of them would have an injury to the brain. With this observation, it is estimated that there could be a nearly 5 lakh deaths every year due to traumatic brain injury in India. If we see this pyramidal graph, we can see that nearly 10 crore patients visit the hospital for minor care. Out of them, around 3 crore get admitted into the hospital, and out of them, nearly 5 lakh patients become dead due to the traumatic brain injury. It's data of 2014. If we talk about the global incidence of the traumatic brain injury, we can see the lowest incidence is in North America region, that is the US and Canada, is the 4.6%, and however the maximum incidence is Southeast Asia region, that is one of our country is also the part of the Southeast Asia region, and it's around 18.3%, nearly 4 times what the America and Canada contribute in the incidence. If we see the incidence of road traffic collisions worldwide, we can see India is having the darkest color at incidence about 530 per lakh people. It's showing that how much we are burdened because of the traumatic brain injury. If we see the age group affected by the traumatic brain injury, we can see the 2 clear-cut peaks. One clear-cut peak is around teenage and the young adult group, and another peak age group is the age group beyond the 70-75 year. And another thing is noticeable that male are more prone for the traumatic brain injury because of the various reasons outside working and all those. If we talk about the causes of traumatic brain injury, head injury, it is the road traffic accident which contribute the most, around 60%. The second leading cause for the head injury is the fall or accidents, accident due to the falls, and the third one is the assault. Pathological head injury due to the CVA and the head injury due to the sports are the minor contributory. It's around 2 to 3%. If we talk about the head injury type of head injury according to the percentage, we can see here that the mild head injury is around 45% and moderate is around 35%, and the severe head injury is contributing around 20% of the whole traumatic brain injury. If we talk about the guidelines, we have to know about some basics pathophysiology about the traumatic brain injury, what happens once the patient gets trauma. As we all know that our brain is protected inside a rigid non-expansile skull, and the inside material is made up, filled up 3 material, that is the brain parenchyma, CSF, and the blood. And this brain parenchyma is perfused by the arterial blood, and it's usually auto-regulated, that is self-regulated. Once we got the trauma, there is a happening of the traumatic brain injury, its auto-regulatory compensation get disrupted and leading to fatal consequences. So to explain this, Monroe-Kelly doctrine has already been postulated. Here we can see that our whole brain is constituted by the 4 major components, that is the CSF, brain, arterial blood, and the venous blood. Once there is any kind of injury, that is the appearing of the mass effect, if there is a mass effect, first thing which shifts from the skull is the CSF. Once the CSF shifts from the skull, there is a little bit space which accommodates mass effect up to some extent. Once it's started decompensated on the CSF level, then the venous blood get displayed. Once the venous blood and CSF get displayed maximum, then there is a state of the decompensation state started. And this leads to the sharp rise in the intracranial pressure because our brain is confined into a rigid skull. Before I go into the raging intracranial pressure pattern, I would like to explain there are the 2 types of the injury which happen during the traumatic brain injury. One is the primary brain injury, which happen at the time of the injury, that is at the time of the impact. It may lead to neuronal damage by 4 ways, like axonal shearing, necrosis, tissue deformation, and the contusion. And all these phenomena leads secondary brain injury along with the other contributory factors like hypoxia and hypotension. Once the brain goes into the secondary brain injury process, there is a cerebral blood flow auto dysregulation. It's lead to the again hypoxia, and this hypoxia again leads to the cerebral auto deregulation, and ultimately these all things lead to the disrupted energy flow inside the brain because of the mitochondrial failure. And mitochondrial failure, oxygen, hypoxia, and cerebral blood flow, all these cumulatively causes a vicious cycle and leads to a malignant cerebral edema. Because of that, there is a steep rise in the pressure. As we have already explained by the Monroe-Kelly doctrine, there is a up to some point, there is a compensation. It's around the 12 to 13 mmHg where the decompensation starts, and at around the 22 to 23 mmHg of the ICP, where the decompensations rise very sharply, very steeply, because after that we don't have any kind of things which get displaced from the skull. The question is that if we know the pathophysiology and all those things, then we can treat. Then why we need guidelines? We need guidelines because the emergency care in India, especially in India, it is a relatively new discipline in India on which there is a lot of focus of the government as well as the other social agencies now getting. And out of them, our standing regarding the cascade of events that occur after the TBI is also the part that's why we need the needs guidelines, because we have to prevent the secondary brain injury. Management of these injured patients remain quite variable according to place. So if we have guidelines, it will be a universal kind of management over all areas. Either it may be urban, either it may be rural. Instantly, not a single drug has been developed for the TBI during the recent time by which we can claim that trauma has some kind of significant improvement. It is the only adherence to the guidelines which has made possible to reduce the mortality due to the TBI. The mortality from the severe TBI in the United States has decreased from 51% in 1977 to around 20 to 30% currently by just implementing evidence-based management guidelines. So we can see the need of guidelines for managing these patients. Guidelines, if we talk about the guidelines, is start from the scene of the accident. That is from the scene of the accident to reaching up to the hospital is the guidelines which has been defined as a pre-hospital guidelines. We can see that 20% of the injured patients die at site after accident, and if these patients could reach to the hospital, they can be saved. The first 60 minutes after the trauma have been identified as a critical period for transporting patients from the scene of accident to the health care center, preferably a trauma center, and has been called as a golden hour. And now the concept of golden hour is being accepted widely. During the pre-hospital care, the caregivers had to manage airway, breathing, blood pressure, cardiac arrest, GCS examination, pupil examination, as per the realistic protocol of that particular situation and the available resources at that particular site. So ideally, 3 critical steps must be taken by each and every caregivers. That is the examination and the recognition of the severe head injury with potential to cause rapid decompensation, and stabilization and transport to the hospital of the addressing the identified injury, what in the point number 1 mentioned. And third one is the performance of the efficient triage if multiple victims at accident site. And we can see here in the image that how head injury patients can manage by the lock rolling system. I'm especially giving emphasis to stabilize the cervical spine while transporting these patients. So to manage in the pre-hospital settings, airway, blood pressure and the circulation, the airway must be assessed first in all trauma patients. If patient can talk, then airway does not need immediate intervention. It's mean your airway is okay. If noisy, it's mean there is it's a sign of there is a compromised airway. It's require immediate intervention by using the jaw thrust, by removing foreign body and oral suctioning and all those, we can insert the oral airway also available in the emergency ambulances today. Protect the airway head injury in head injury patients in the least invasive manner because possible incidence of around 10% incidence of cervical spine injury. And high flow oxygen must be supplied to the all patients as soon as the airway and breathing are secured. And oxygen saturation should be continuously monitored with pulse oximeter and saturation should maintain more than 90%. To control the bleeding, we have managed all the external hemorrhages first with compression bandaging, splint over the long bone, especially the lower limb, especially the femur. And decision to start IV fluid on the scene depends upon the severity of the hypotension. If there is a less hypotension and no hypotension, it's better to rush to the hospital. Do not waste the time into starting the IV line. If there is a hypotension, first put the IV line and start the fluid at the maximum rate and rush to the hospital. And we have to make all effort that systolic blood pressure should be more than 90 mmHg in adult trauma patients. If there is a happening of cardiac arrest and we found no palpable pulse, the basic life support must be started and continue without interruption until we reach to the hospital. Meanwhile, we have to examine the GCS and the pupil of the patient. It's a good and reliable indicator for the severity of TBI. And it should not be assessed until the oxygenation and the blood pressure has been normalized. And once it gets normalized, we can assume repeated assessment for GCS and the pupil if there is a chance to identify the improvement or deterioration over the time. And the left and right pupil, we have to see the separately. And if there is a more than 5 mm disparity, then we should consider it asymmetry. Once we reach the hospitals, then we have to follow the hospital care guidelines. And being a clinician is the most important for all of us because we usually receive the patient at this end. And there are clear-cut guidelines from admission to discharge. It started from the hospital selection to resuscitations and how we will monitor the patient, how we will offer the treatment, and how we will discharge to these patients. While selecting the hospital, it should be selected according to the, as per the severity of the injury. For severe traumatic brain injury, level 1 trauma center, while for moderate to severe traumatic brain injury, level 2 and level 3 trauma center should be preferred. Patients who don't need CT can manage as the level 4 trauma center. So again, as I have described in the pre-hospital guidelines resuscitation, we have to do the assessment and intervention for resuscitation simultaneously. And first of all, we have to take care the airway and the breathing. Assessment and intervention should ideally done as follow. Talk to the patient, as I've already discussed. If airway is secure, nothing to do. If does not speak, we have to go for jaw thrust, removal of the foreign body, oral suctioning, and all those things. Even after this breathing is noisy or there is a significant blood in the oral cavity of the patients, need a definitive airway management. Then we have to go for the endotracheal intubation, the LMA placement. If not possible, then we have to go for the cricothyroidectomy, not for the tracheostomy. Tracheostomy is not an emergency surgical intervention. And once we secure these, we have to connect the patient with the high flow oxygen. If a definitive airway was not initially necessary, frequent reassessment of the airway is mandatory because patient may need this at any time. If breathing is still inadequate, rule out the reason for rapidly correctable things like tension pneumothorax because this may, after correction, after doing all correction, your breathing, your patient's breathing may be abnormal because of the tension pneumothorax. To correct the blood pressure and the circulation, we have to take care that hypotension is extremely dangerous for the brain injury because it leads to the hypoxia and consequently the brain edema. So we focus on the rapid correction. If blood pressure is low and the patient has tachycardia with borderline blood pressure, start large caliber peripheral lines in both antecubital fossa and administer dextrose-free castelloid Please mind, we have to administer the dextrose-free crystalloid to all head injury patients. We should not give any fluid who is containing the dextrose. And we have to send a cross match for the emergency blood transfusion if it not controlled by the infusion of the crystalloid. And simultaneously, we have to take the measures to control the wounds, external wounds. We have to go for the fast. And if there is a fast positive, we have to inform our surgical colleague immediately. We have to do the pelvic compression test. And if there is a positive, we have to apply the pelvic binder. If there is a fracture in the femur, we have to go for the splint. And meanwhile, we have to continuously administer the crystalloid. And we have to monitor the pulse and blood pressure. After more than 1 liter of the fluid administered, ringer electrode is preferred in the TBI. If the blood pressure does not respond to the crystalloid and alone, then we have to go for the cross-match blood. And cross-match blood is not available. Then O negative blood we can transfuse with the consent of the patient. And the surgical control of hemorrhage may be needed if the circulation can still not be stabilized. Once the hemorrhage is controlled, vasoactive drug can be used to raise the blood pressure if the suitable monitoring is available. The treating personnel should examine and make every effort to exclude, especially in unconscious patients, the easily overlooked cause of the hypotension, such as cervical spine injury, abdominal injury, pelvic fracture, and the fracture of the long bone. It should be assessed and reassessed. So if we don't have the facility to do the all kind of resuscitation which have been mentioned, so before referring the patient, we have to do minimum with the patient. So assessment of the ABC remain unchanged and should be documented for the benefit of subsequent management. Because many times at the higher center we receive the patient, but we don't know patient what have been given to the patient. And if a definitive airway is not possible, then secure airway as best as possible. Treat any easily treatable cause of impaired breathing like tension pneumothorax. Make patient semi-prone and refer urgently. If definitive air placement is possible and the breathing is inadequate, then connect to the ventilator. If you don't have ventilator, then refer the patient as soon as possible. If blood pressure is low, start rapid infusion of the crystalloid along with the vasopressors and refer urgently patient while continuing the rapid infusion of the crystalloid en route along with the vasopressors. So once the patient, once you found the patient that you have the all facility and you are ready to the admission, then how many times left? How much time? 5 minutes. Okay. Then we have go through the criteria for admissions, like history of loss of consciousness, age more than 65 years, Glasgow coma score less than 15, deteriorating GCS, for any focal neurological deficit or post-traumatic seizures, or patient having the extreme age with coagulopathy and taking anticoagulant, or patient having the CSF plaque. So we have to admit all those patients. And out of them whom we have to go for the CT scan, the patient with the GCS less than 13 or patient with the post-traumatic seizure, post-traumatic neurological deficit, suspected open on the skull base fracture, patient with the sign of the skull base fracture like panda eye sign or raccoon eye sign and the battlefield sign or CSF from the nose or ear, and the extreme of the age patients like more than 70 years, less than 1 year, patient with retrograde amnesia more than 5 minutes, vomiting more than 2 episodes, and patient with the persistent headache. So once the patient admit, we monitor the patient according to the guidelines. We have to done monitoring outside the ICU and inside the ICU. Outside the ICU, we have to monitor the pulse, BP, clinical assessment, temperature, GCSE score, and inside the ICU, we have to add, along with the other monitoring, we have to add the invasive measures to measure the BP and the ECG and in-tidal carbon dioxide measurement. And if possible, we have to go for the intracranial pressure monitoring. So the frequency of monitoring, if for systemic monitoring, it's crudely every 2 hourly for first 6 hours. And after that, once the patient is stabilized, every 4 to 6 hourly. And for neurological monitoring, every half an hour till the some sign of neurological improvement, and then every hourly till the 12 hour, and subsequently reduce the frequency every 2 hourly if there has been some improvement after the admission. Treatment guidelines, I have already explained about the fluid and electrolyte management. We have to avoid the dextrose, and simultaneously we have to monitor the sodium and potassium every day, especially if there is a mannitol or protonic saline is ongoing. For the seizure management, there is each and every patient who is getting admitted should be loaded with the suitable anticonvulsant like phenytoin, fast-phenytoin, or levetiracetam for first 7 days. After 7 days, there is no role of any anticonvulsant for the traumatic brain injury until unless the patient have some kind of the risk factor like early post-traumatic seizure, or patient is having more than 65 years age and patient is in the pre-morbid history of depression. And prophylactically, we have no role of the anti-epileptic for managing the seizure, for late onset post-traumatic seizure. Analgesia and sedative management, it's important for acute TBI to control and prophylaxis for the intracranial hypertension and the seizure. Suitable analgesia should be given to reduce the ICP. Sedation should be used only by the experienced person only. And short-acting medication are preferred. Use of sedation in wards should be discouraged. And infection prophylaxis, no recommendation for the prophylactic antibiotic in the TBI patient in situation of the, even in situation of the CSF leak, otorrhea, insertion of ICP electrodes, anything, until unless you found some active infection, infective foci. Antibiotics should be given only for the compound depressed fracture or scalp laceration, and do not use the povidone iodine for the oral care because it's increased the risk of the ARDS. Early tracheostomy is recommended to reduce the mechanical ventilation. It has no benefit about reducing the mortality of the TBI or reducing the nosocomial pneumonia. Nutrition, patient's nutrition should be started at least by the day 5th, and it should not be delayed by the 7th post-injury day. If possible, go for the PEG. It is superior than the rice tube feeding. To manage the RAGE ICP, we have to some general measures like head elevation, airway, and breathing must be normal, blood pressure should be adequate, temperature and the sodium must be corrected. Some medical measures like hyperosmolar therapy with the mannitol as well as the 3% saline. If ICP is not controllable even after the medical management or and there is no lesion that can be removed, then we go for the decompressive craniectomy or barbiturated coma. One thing is here is noticeable that we should not use steroid because it is the only level 1 evidence that we should not use the steroid. Steroid causes more mortality and morbidity than anything, and it's a very misconception that steroid reduce the ICP. So few word about the ICP monitoring. It should be done in all severe TBI and severe TBI with normal CT less than 40 areas with unilateral or bilateral motor posturing. So ultimately, once we found any surgical treatable cause, we go for removal of this, and the decision should be as per individual neurosurgeon. Bifrontal DECRA and right-sided frontotemporal decompressive craniectomy, 2 things can be done, but the large frontotemporoparietal DECRA is recommended over the bifrontal DECRA. It's the level 2 evidence. For the discharge guideline, it's very important for any general practitioner because we used to have referred the patient to the higher center. So once we refer the patient higher center, we barely find anything from the referral center that what kind of medication the patient has get till now. So we have to follow the guidelines. And few word about the rehabilitation guidelines. About 10 to 15% of patient of the mild TBI and 40 to 50% of moderate, and about 100% patient after of the severe TBI required the rehabilitation during their treatment. And there should be the provision of indoor provision of the rehabilitation bed, manpower, equipment, and space to provide optimum care, especially at level 1 and level 2 trauma centers. If we don't have rehabilitation facility, then we have to take at least some rehab principles just
Dr.
to take
Pawan,
care of the temperature. Sir, bas finishing in the 5 minutes, sir. Just to take care of the bed sore, prevent the choking, facilitating the breathing, management of urine, feces, eating, drinking, sleeping, washing, bathing, walk, and we have to manage the agitative and destructive behavior by the counselors also. Here are the few measures shown here. And on the outpatient basis, we can manage the patient's speech, language, headache, vertigo, cognitive rehabilitation, and psychiatric symptoms. So to summarize, In the old time, we used to go to nearest hospital, inadequate assistance with hyperventilation. Surgical delay or omission because of misconception in the community, inadequate resuscitations, inadequate facilities and the personnel, no brain or the pressure monitoring, use of large amount of the steroid, and there was no protocol. Delayed in the rehab, and there was a lot of medical complications. So we end up with the bad outcome, lot of cost, family burden, violent or aggressive behavior of the patients, and severe disability. But by the new way, we can shift the patient to the trauma centers with full resuscitation, brain-targeted therapy, rapid surgeries, with brain pressure monitoring and optimized brain perfusions, with close bedside visual monitoring, with integrated rehab to prevent all the complications, which leading to the good outcome in the form of less cost, less family burden, more socially integrated patient, and with less severity disabled patients. So to conclude all those, the rapid expansion of the highways, poor adherence to the traffic rule, and the lack of the proper referral of injured patients are the major responsible factor for resultant death and disability due to traumatic brain injury. It is the only secondary brain injury which we can prevent by timely intervention. So adherence to the TBI guidelines are the key to improve the final outcome of the patient, to make them maximum independent rather than burden on the family. The purpose of these guidelines is to improve the entire spectrum of the TBI care, from awareness, prevention, pre-hospital care, in-hospital care, and finally the rehabilitations. These guidelines are the living documents that can be modified and improved with new knowledge and ongoing experiences in the near future. Thank you so much.